to be with us this afternoon. We've been talking, and last time when we had the very first call, we talked that diabetes is now a HRSA priority, and that HRSA is working with different organizations to improve the AC1 greater than 9 quality performance measures among all health centers. Uh, Yesterday, I was part of the subcommittee that NAC has put together, and we had a very good conversation with some health centers, some primary care associations, some national cooperative agreements in regards to diabetes and the next steps and creating a roadmap to try to improve the numbers. One of the questions that we got during the call is basically if there will be some kind of additional funding to do all these activities. And because of the health center funding cliff, uh, at this moment, I don't think that this is that's gonna be happening anytime soon. So the idea that all health centers and primary care associations and all the organizations have is to work with the resources that we have. So that's one of the diabetes updates that I would like to provide to everybody on this call in regards to where we are on all these activities. There is also some other groups working on diabetes, and the 20 national cooperative agreements have created a SDOH Academy, a Social Determinants of Health Academy, and the academy is HRSA funded and will be providing some virtual training series designed to health center staff, primary care associations, and other organizations. And they are going to address diabetes and social determinants of health. So from January to June, the Academy will offer some virtual trainings, specifically webinars, and after the webinar, some virtual office hours where you can ask questions and share your experience. So this is another opportunity to discuss diabetes and all the good stuff that you are doing at your health centers. The the other resources that we have is we have created a map. The map is an interactive map where you can find the map shows the number of and percentage of patients with diabetes and uncontrolled diabetes among the health centers, specifically public health and primary care health centers. And the map shows or displays county level diabetes data and health center data. So if you would like to know how you are doing and compared to your state and your county, this is a very good resource that you can use to to show during your clinical quality meetings. There is another activity, and this is there is a. Let me see if I can. I'm not sure if you are able to see my slides, but there is another tool created by another organization where you have a UDS data. This is 2016 data, and you can have information on the number of patients with uncontrolled diabetes. And this is for all the 1,400 or around 1,400 community health centers. You can find reports by special population and compare how you are doing with compared to Healthy People 2020 objectives. So these are three tools that we can share if you need additional information. So you can get all this information and talk with your staff and see how you can improve diabetes and diabetes care. Today, I would like to briefly discuss on some of the community linkages and how you are working with the community to address the diabetes epidemic and the patient with A1C greater than 9. There are several organizations that you can work with. Uh, I can mention public housing agencies, federal and state organizations, the Department of Health, County Department of Health. Um, there are other organizations such as YMCA and organizations at the community level that you can have linkages to and work with them and address the needs of the patient with diabetes. There are a couple of examples. There is a health center in Chicago who is providing to the diabetic to their patient with diabetes a food prescription, and the food prescription is with they also are given to patients a fact sheet on how to eat healthy and the type of food that they need to consume, and at the same time they are providing some discounts. They are working with a pharmacy, Walgreens specifically, and offering some discounts on food that they can get at Walgreens, and they are also working with some farmers market and providing some discounts for the patients. And so these are some of the activities that some of the health centers are doing with the community. And there is another one in particular that I found that is very interesting. There are some health centers in Montana, and they are using community health workers and telehealth to communicate with patients with diabetes in rural areas. What the community health workers are doing is that they are securing pool spaces, for instance, at local hotels, or they are working with some organizations to provide exercise equipment at local recreation centers for patients so they can exercise. So those are the kind of activities that I have research on, and we've been talking to some of the health centers that's what they have shared with us. And the other one that I found very interesting was the social network linkages. I'm not sure if you are using social media or social network to communicate to patients. There are three activities in particular that I found very interesting. One is an activity that is Text to Be Fit. This is for patients, for young patients with diabetes, and they can download an app, and the app provides information on and tips on diabetes for young young patients. The other program is the eHealthy Strides from the American Association of Diabetes Educators. What they are offering is this is an electronic support program, and they offer resources to patients with diabetes. And there is another program which is My Diabetes Wellness Program, and this is an interactive portal that provides self-management tools with patients with diabetes. So I'm bringing all these resources up just to gather some information from you and ask you what kind of activities you are doing with community organizations to provide services to your diabetic patients. Does anyone have any comments or any activity that they would like to share with us?
I'm Dr. Ibrahim. Actually, we have a health department in Wichita Falls that we are working very closely with them. They have a diabetic education class, and also they have a cooking class. And when we send our patients over there, I heard that majority of our patients, they are very happy with that program. And whenever they have a class, they're going to send us a link, and they're going to provide us the date and the time of the classes. And we have a behavioral health here in our community health center, and then through them and also through the providers, we are educating our patients to go over there. In the past, we run a report on those patients that they have A1C more than 9, and we gave the list to our behavioral health, and they contact all those patients on the phone and educate them. Some of them, they went to the health department. Some of them just, they declined it, and they received diabetic education on the phone, over the phone. And we lowered the A1C from 9 to 8. Our UDS report was very good.
Oh, okay.
And
what was the time interval, Dr. Ibrahim? I'm sorry.
I think we did it almost for 3 months or 3 to 4 months. It was every day they are just calling the patient and then educating them over the phone.
Okay, and what is the duration of these classes? I mean, is this a program that lasts a couple of months?
It's a 6 weeks class.
Okay, okay. That is great. Now, in regards to exercise and for patients that either are pre-diabetic or overweight, is there any program in the community that you are doing, or at the health center level that you are providing some kind of wellness program or exercise program?
Not at this time, but we have a YMCA and we have a 50+ program that we can refer our patients to. But actually, it's kind of expensive for our patients to go to YMCA. But the 50+, it's $20 per year. And honestly, we want to start a research program just focusing on the diabetes. We already applied, and they are needing more information. What we want to do, we want to get some money from the American Family Medicine and then try to figure out what are the barriers that our patients, they are not able to lower the A1C. And we have a questionnaire. We chose 5 or 6 questions, and then we're going to give it to our patient. And for example, if they have food insecurity, or they are not able to exercise, or they are not able to pay for their medication, or whatever that we find out through the questionnaires, we're going to focus on those. And then we are planning to have 300 patients on this study and try to help them to get, for example, to YMCA or 50+, or those that they don't know anything about the diabetes. And we're going to refer them to the health department. And also we are using our behavioral health to educate the patient. It's just a very lengthy process that we started it just because we know diabetes is something that we have to focus on. And most probably in 1 month, we're going to start the research program. I heard that somehow if we start doing the research program and bringing some money to the system, helping the patient, getting the information and educating them, you know, it's going to help the center, because we have to use our employees to call the patient and then bring them back, educate them, all those things. Maybe by integrating the research program to our kind of program and educating the diabetic patients, somehow it's going to help us.
That is excellent. Thank you so much for sharing that, Dr. Ibrahim. Now, do you work, I mean, you mentioned your local Department of Health or state health department. Do you have any partnership with them in regards to diabetes prevention or diabetes management?
We go over there for the meeting, but I don't know, what do you mean regarding the partnership? We refer our patients over there.
Okay.
And they accept our patients. And other than that, you know, during this class, a specific class that we send the patient over there, they educate the patient, they cook, and patient eats over there the same food that they, you know, make. And then after that, they exercise.
Mm-hmm.
It's just a very comprehensive diabetic education class. We have hospital here that we send some of our patients over there, but those patients, they are not happy with the hospital diabetic education class, but they are very happy with the health department.
Interesting. Dr. Abraham, how do you assess progress? I mean, when the patient is back, do you go back and test patients for A1C, weight management, and all that stuff? Is that how it works?
Um, Here we have a system that we want those patients that they have A1C more than 9, they have to come back every 3 months.
Okay.
And then we run a report. If we see those patients, they didn't show up or they didn't come back for the A1C. We have 8 nurse practitioners and 1 MD. And we run a report, and we're going to give the nurse for each practice the name of those patients. They are calling the patient and reminding them, okay, your A1C was high, we want you to come and see us, or you have to repeat your A1C. This is the way we are just following on those patients.
Mm-hmm.
And also, when we see the patient here, we schedule the patient to come back in 3 months, and then the call center, they're going to call the patient and remind them that it's time for them to come to the clinic.
Mm-hmm.
If no show, and then the call center is going to call them back and say, you didn't come to the clinic. Do you want to make an appointment again?
That's fantastic. Now, in regards to weight control, do you have dietitians and in your staff, Dr. Ibrahim, so they can provide some recommendations and guidelines to the patients on how to eat healthy?
We have a package. We have a standing order that, for example, if the patient has diabetes, all the staff, they know, even the front desk, pharmacy, they can use it, and they can refer the patient to our behavioral health.
Mm-hmm.
And our behavioral health, actually, they went to those diabetic education class. They know what's going on. They know they have a package to educate the patient regarding the diabetic medication or diet. Also, we have another package that if the nurse wants to educate the patient, they can do it. We try to educate everybody as soon as they have a patient with the diabetes that they know they don't understand the diabetic, they're going to go ahead and educate.
Mm-hmm. Now,
and I find that CDC has a really good, actually, diabetic education material that it's fantastic. It's easy to understand. And for our research program, we would like to use those information because it's very easy. We can print it, give it to the patient, and they can use it.
Are you referring to the diabetes control program, the CDC's diabetes control program?
Yes. Mm-hmm.
Now, if I'm not mistaken, and correct me if I am wrong, sometimes you need to receive some training to provide the diabetes control program, either in your clinic or at any other organization. Have you or has anybody received that training?
No.
No.
I
Okay.
didn't know that. Mm-mm.
I mean, it seems that you can download all the resources that they have, but at the same time, if you want to be, probably the word is not licensed, but if you want to be recognized by CDC that you are doing that, I believe that there is some kind of training that you can receive at your state, I mean, at the state level.
Oh, okay. That's good to know.
But this is fantastic. Thank you so much for sharing that information.
You're welcome.
Kathy, is there anything that you would like to share with us?
Well, I'm not going to speak at length. We've been doing group meetings with diabetics. We have a series of sessions that they come to in the group meetings that seems to have been valuable. We recently introduced the SMART form, which is in ECW for assessing prediabetes. Gosh, we had some money from the state health department that allowed us, that ended I think last year, that allowed us to do some additional projects in our electronic medical records, specifically targeted towards towards reporting for diabetics. We actually, what we do now have is we have Tableau, which creates dashboards for us of, according to provider, according to site, patients whose hemoglobin A1Cs are, below 8, between 8 and 9, above 9, and we're beginning to distribute those to our providers, and that's seeming to give some sort of boost to the providers and working even more attentively with their diabetic patients. So, other than that, I can't.
Do you
I have a question for you. I have a question for you. You mentioned that you have a group meeting. How do you encourage or convince your patient to come to the group meeting? We have a problem here that our patients, they don't come to the group meeting. We tried it several times and we are not successful.
Okay, yeah, I'm not the person to answer that because I'm not involved with the group meetings. I can certainly take your information and have the person who works on that. I know what I've done in the past in other environments I've worked in that has been highly successful in getting them to come to appointments and all was a lot of personal outreach. Having someone call and say, and I used to get, this was in a different environment that I worked in. It was actually for a free clinic that I worked in. But we would get 100% turnout when we made personal calls and made sure, did you have transportation? What's the barrier? Well, we'll work with you to resolve it. So, sometimes it's a lot of really intimate detail, knowing what each person's situation is.
Okay.
So, and I think it's important to find out, I don't know what your setting is. Is it in the evening? Is it a time that's suitable for them? Would they prefer it on a weekend? How adaptable can you be to what patients say that's going to work for them? Do they need child care? All those little things. So.
Actually, we asked diabetic education group to come to our clinic for at least 3 months every day. And we had one class in the morning, one class in the afternoon. We had maybe 1 or 2 patients, they showed up. It was very difficult to, we called the patient, we asked them, all the nurses, they got involved referring them, but they didn't come.
And this is Joy. I think we've done a lot of similar things with group visits and things, and I think that part of what really drives people to come over time is the content, and I think diabetic education per se is something that people aren't necessarily interested in. I mean, sometimes if it's just information, they already know that information, they've heard it before, they don't want to hear it, whatever it might be. But I think if it's more of with a really dynamic leader who connects with them is really critical. And like for us, what has actually worked pretty well is we found that people were coming to our exercise classes, but not necessarily to our nutrition class or to our education classes. So what we did was we put our diabetic education into an exercise class, and that has been very successful. We're actually at the point now where people would keep coming back because they, like, nobody wanted to leave the class, partly because they really bonded with the instructor and the other participants, and they want to keep doing the exercise. So now we're actually deaggregating them again. So when people start, they go to a special kind of intensive 6-week session that has exercise and the education, and then they graduate to just the exercise only class. But I think
that's interesting. I really need to get more information regarding the exercise class.
Dr. Magui, can you elaborate? I mean, there was a presentation at the ACU conference from El Rio that I believe it was really, really, really good on the exercise program that you have. Is that any? Can you please share that with the group?
Yeah, sure. So I'm not personally, involved in the delivery of it, but I definitely have many patients who have gone and go, and am pretty knowledgeable, I would say. But so that's basically how it started, is that we found that our nutrition focus classes really was kind of like what Dr. Abraham described, that it would be, despite offering different times of the day and things like that, trying to deal with barriers, it'd be like, 1 or 2 people would show up, and it was pretty demoralizing. And we were referring a lot of people out to the more formal diabetes education classes at the hospitals, and nobody was going to those. So what we did was we have some really dynamic fitness instructors who are bilingual, bicultural, and really connect well with the community. And so we got them more information specifically on diabetes and developed a whole curriculum. And then we started having our dietitian and, on a rotating basis, our clinical pharmacists and our behavioral health consultants all going to those exercise sessions. So it eventually became about 30 minutes of content at the beginning, which wasn't just education. It really is also a lot of more motivational interviewing facilitated by the group. So really more of trying to get people involved and conversing about what, how they can make lifestyle changes for themselves and what their values and goals are, and how to achieve those. And then followed by about 45 minutes or an hour of exercise. So, the problem is, compared to our overall population, we are still reaching a fairly small group with those, those sessions. And so what I hear from patients are, sometimes it's just the time, they just can't make the time, or the specific hours and childcare and, all those usual barriers. But what we're doing is we are trying to just expand our own capacity, because we were also just filling up the classes we had available. So creating that second sort of tier with less content and more exercise for the people who are getting a lot more fit and want to continue.
Great, excellent. Thank you so much. This is very helpful. Now, Kathy, is there any, do you offer any exercise and weight control program at ZUFO, or do you work with any community-based organization?
No, we offer classes here at Dover, downstairs in the evenings, and we also have a site in Morristown that offers classes as well. I haven't looked at them recently, but it's not, we don't have any fitness equipment. We have kind of yoga classes. I'm not familiar with what's on the schedule at the moment.
What about nutrition? Do you have a dietitian in place, or?
Yes, we do.
Okay.
And
do
we
you
also, for our diabetics, we have 2 pharmacists who meet with, the high-risk diabetic patients and hypertensives. They get a really concentrated, intensive session, and they, follow up with them on weekly and monthly basis. So they get a lot of attention.
Now, what about working with the public housing agency? Do you have any kind of health fair or any other activity with the public housing agency? Not only for diabetes by weight control or any of the chronic diseases that are affecting your population.
I'm not the best person to ask that. We have a director of outreach,
Mm-hmm.
or so I can't. I'm not too involved with that level of activity. So
Okay.
I think we do. I mean, we had an HIV/AIDS Day for International, HIV Day. I just can't speak to how often and all of that. I
Okay.
mean, I can get the answer for you.
Thank you. Thank you so much. And Dr. Mugby, in addition to the activities and the programs that you have in place, do you work with any community-based organization?
So we do. I would say the bulk of things we do are in-house. We do ourselves, like all of our fitness classes. We also have, Zumba and yoga and bar and Get Fit and Zumba Gold and Matter of Balance, a bunch of different things. But we do partner. We're in the process of developing a food RX kind of, food, like one the other people mentioned, kind of food as pharmacy prescription program in conjunction with the community food bank, a local university, and some other community partners. And then we're also working with the National Health Service. The National Park Service to prescribe parks, and they're setting up different maps and kind of like resource guides and guided activities at the national parks and other local parks in our area. And then we're going to be doing prescriptions. We're going to have like these kind of lead activities. But I would say that, definitely reaches a smaller percentage of our patients as compared to the overall amount of care we're providing. But we are working with those community organizations.
Yeah, are you folks aware that the Park Service may want to charge a $70 fee for a visit to the parks per day, the federal park system? And so we really need that's if you're saying that you use the federal parks, that may be a
Yeah, and so
up.
these are specific activities, yeah, that would be, they actually have funding, like they actually are working on getting vans to help. So we have one national park, both two different sites in our community. Saguaro National Park, we're very lucky. It's like right in an urban area. It's one of the urban national parks. So pretty easy to get people to with vans, and they're actually finding funding for all of that and for park entrance, as well as just local city and county parks. So really trying to incorporate resources that are for free. Yeah, I mean, we're fortunate to be able to get around some of those national park fees.
Excellent. Now, one of the questions, and this is something that I have noticed that every day people are more into social media and resources on online resources. Is that an activity that you are tapping into? Is there something that any of the health centers are doing?
This is Joy. We have an intern, a master's level public health student, who is going to be working on that for a weight management program starting in the spring. But so far we've talked about it a lot, but we haven't actually gotten it off the ground.
Mm-hmm, mm-hmm. And what is, I'm sorry, just to ask you this question, but is there a plan on what are you planning to include in that kind of activity or training?
Well, so it depends on what comes out of the students' work. But what we are thinking is that for some of our specific group-oriented programs, like our starting with our weight management, which we do in cohorts, basically, that we would use social media for a particular cohort, that they could all be on a specific social media group, and that they could support themselves, and then support each other, and then we would send out different educational and motivational information, reminders and things like that also over the social media. But the details definitely are not at all developed yet.
Mm-hmm. Now, you mentioned that this is something that some students are going to develop. Are these college students, medical students, or do you have any kind of collaboration with a university?
Yeah, so they are master's level College of Public Health students, so getting their MPHs. And we do have a lot of collaboration. So we also have undergrad public health students. We have pre-med students. We have medical students. We have nurse practitioner students. We have nursing students. We have a lot of students. We have dental, pharmacy, a whole gamut. So
that's
residents.
great. That's fantastic.
Yeah.
Okay. What about Dr. Abraham? What about the activities that you are doing at the community healthcare center? Do you work with universities too?
Yes, actually, we have PS students coming from AT Steel, Arizona University, and then we have a college in Wichita Falls. It's a MSU. We are getting nurse practitioner students from MSU coming, 5 of them actually. They're going to start in January, and then after 3 or 4 months, we're going to get another 5 more students. We have 24 residents, family practice residents working with us. We actually took over the residency in last January, and then we are working very closely with the residents.
Okay.
Still, they are learning about the FQHC and all the rules and regulations, but yes, we have them.
Thank you so much. Now, who is providing diabetes education? Do you have a diabetes educator per se, or someone who specializes in diabetes, or is a community healthcare worker or a nurse practitioner? Who is providing that education?
Actually, in our clinic, we use our behavioral health personnel. We have 3 of them. And then, as I said, we have standing orders. We have, whenever the patient comes to our clinic, everybody can refer them to the behavioral health. And they are educating our patients. They are calling back. They are following up on those patients. And it's working pretty good. But still, diabetes is something that we have to watch them very closely. Just depends on which month, or what type of month, or because right now holidays, and then we have so many patients coming with the A1C going higher than 10, and I'm just thinking that really we have to watch them very closely.
No, you're right, and thank you for sharing that. Kathy, do you have some agreement with colleges and universities too, right?
Yeah, we do. I know we're doing some pediatric rotations right now. Yeah, I'm not the best person to speak to this. I'm not highly involved with this.
Okay.
Uh,
All right. And Dr.
One time we had some pharmacy students, and we had a change in pharmacists, so I don't know if we still do. We have an agreement with Fairleigh Dickinson Pharmacy School, which we may still have. I'm just not highly engaged with those activities. So.
Okay. Dr. Mugby, do you have diabetes educators in a Rio?
We have a lot of people doing that role. So we have all of our clinical pharmacists are certified diabetes educators, as is our dietitian, our dietitians, and some of our other wellness staff. And then we really rely on the entire team as well to work on the education.
Mm-hmm. Now, is there anything that you are not providing to your diabetic patients that you have to refer them to some kind of community organizations or clinics?
No, I mean, I think
Actually,
for us, really, we are the referral source.
Okay, okay. I'm sorry, Dr. Abraham.
one of the things we find out that some of our patients, they cannot afford their medications.
Mm-hmm.
They are sharing with the family member, and then when we are asking them, you need to take this much, and they are telling us that they cannot afford it. We have interfaith outreach services in our community, and then we refer some of our patients, or I don't know how many of them they go over there, but they interfaith outreach services, they have some protocols. If the patient falls in their protocols, and then they're going to pay for the patient's medications. And they have some of our patients actually going over there for maybe 9 years, getting money from them to pay for their medication.
Mm.
We have a really close relationship with them, and also this organization helping us because some of our patients, they don't want to pay a copay to see the behavioral health, to get the education for diabetes or get the education for depression or anxiety. And then the outreach services agreed with us that they can pay for half of the visit, and then we pay for the other half.
Okay. This is great. Thank you so much. Now, and this is probably the last question that I have, and is when you have some diabetic patients with other chronic medical conditions, sometimes you have a patient with diabetes, for instance, who are smokers, or they have a high blood pressure, or they have a kidney issue, and I imagine that everybody has agreement with hospitals and other clinics, but is there any particular program that you are involved with, that you are offering additional resources for diabetic patients to address other chronic medical conditions?
Yeah, I mean, that's the bread and butter of primary care, is that it seems like everyone we see has literally, I mean, not exaggerating, 10 different problems that are all intermixed in various ways. And so really using that comprehensive team, I think, is really important. I think we're definitely better positioned than a lot of private practices and other more traditional practices to address those multiple comorbidities. And so I think that's really, and then just trying to make things as easy as possible, because it is so overwhelming for people who have so many different competing things going on. So and one of the things that's been, I think, one of our biggest successes recently is about a year and a half ago, we got diabetic retinal cameras for the diabetic eye exams at our site. And so instead of doing a referral out to ophthalmology, we can just, when they're there for the appointment, just walk them over to the camera and in 15 minutes have that retinal exam done. And so things like that, really trying to not rely on outside places that are just create more barriers, but trying to streamline how we can provide the services.
Yeah, you're right. So basically,
and I guess actually the one thing I wanted to think, just in thinking after I had said, we kind of are the referral source, I think the big thing that we don't and can't provide, which is really a paradigm shift in treatment of diabetes, is bariatric surgery. So, the new, it's about 2 years old now, the Endocrine Society guidelines recommend for anyone with a BMI over 30 who's not well controlled on metformin alone, that bariatric surgery, is indicated. And so, or is a treatment option. And really, when we start looking at that, that's like almost everyone we see practically. And, the vast majority of our uncontrolled diabetics fall into that category. And so really changing our thought process from diabetes being a medical disease to being a surgical disease, So working with our community partners in that way, I mean, people do, it's much harder to get if they're totally uninsured, although there are some payment plans and things available. But for our patients who have Medicaid and other insurances, it definitely is a viable option, and we just have to really work the linkages and the long-term preparation and follow-up.
Yeah, and thank you for bringing that up. I've been reading some research on bariatric surgery, and it seems that this is a procedure that is now more recommended for patients, as you mentioned, with a BMI over 30. And however, do you know if there is any guideline for those community health centers that they can read or research on, Dr. Magby?
Yeah, I mean, I think the Endocrine Society recommendation or their guideline, which I think was released in February of 2016. I think if you just search like Endocrine Society diabetes bariatric surgery guideline, something like that, it'll come up.
Okay, all right. That's a good help and source of information. You know, that's something that some health centers can explore and offer that kind of services if needed in their diabetic.
Yeah, and I think the data is pretty clear that it can, in people who are early stage. So once you burned out your pancreas, it's a little bit too late. But for people in early stage, it really can cure diabetes, as well as addressing many of those comorbidities, the hypertension and hyperlipidemia and knee pain and depression, all these other things. So I think at least offering people the recommended guidelines, these are your different options with a shared decision-making approach is really important.
Yeah. Thank you so much for bringing that up. Is there any other topic that you would like to include in this discussion? Anything that I may have forgotten? Dr. Ibrahim, is there anything that you would like to share with us?
Actually, we have a retinal screening program in our clinic, and we are working with a group that they do the telemedicine. They read the retinal images, and then we started 2 years ago working with them, and then this one also is a research program. And then by doing it, we realized that this year, actually, we increased the number of the diabetic patients that they already got their retinal screening significantly. And then because it's free and they get the incentive, during the process of the research, we order labs, and also they come for the labs, and then after that they go for the retinal screening and they get their incentive. And then after 6 months, they come back to repeat it. This research program, they are looking to find out if there is any relationship between the retinal damage or any disease and high blood pressure and diabetes. It's very unique, and it's interesting to see the data. It's just coming out. We almost registered 300 patients for this research program. Yeah.
Oh, that's fantastic. During what interval?
Actually, we started 2 years ago.
3 years ago?
2 years ago. We started, and it's very interesting to see the results and patient coming. And this way, we increased our percentage because we have to do the retinal screening for those patients. They have diabetes, and it was really hard to convince them. But the program helped us to kind of increasing the percentage for UDS purposes or meaningful use.
And do you know when you're going to have some preliminary results?
They are coming to us, I think, in next month, reporting the data. And we finished the phase 1. They would like to go to phase 2. And still, there is a gap, maybe 2 months between phase 1 and phase 2. but in 1 month they're going to come and present the whole things to us. They would like to work very closely with the cardiologist, and they are planning to do the other study like a calcium score for those patients that they have high blood pressure and diabetes. And we are working with the cardiologist, talking to them to see if they are interested, and they are very interested to work with us.
Great.
Also, I have a question. I'm sorry. I know you said this is your last question. Maybe this is my last question. Any one of you, do you have any experience with the dots, walk with the dots? There's a program that they started it, I don't know how many years ago, but one of the doctors asked the patient to just go ahead and, walk, and then they start this program. We would like to start it in Wichita Falls.
Yeah, we've done that over the years. Periodically it comes up, and we do it for a while. I mean, I think it's one of those things where it sounds really great, but there's, limited number of people who show up for it. So I think it's a good thing to do. I mean, just for kind of the public relations in some ways, but, and I mean, I think if you could get a group going or in a popular place where it's easy for people to get to at a convenient time or something like that. But I think they're kind of hard to maintain or to get a sizable population.
I heard that it's very hard to maintain it, but they said the requirement is just 6 times per year.
Mm-hmm.
But I don't know. I just want to get the feeling that if it's a good program, we should go ahead and working on it, or if it's not, I don't want to waste my time.
I mean, I think it's pretty easy to do, but it definitely takes that doctor time that, it depends on how many people are showing up. If you can get a lot of people to show up, it'd be great.
Okay.
What I'll do after this call, and if this is something that you agree on, I'm going to share your contact information. So if you have any questions or there's some resources that you would like to share, I believe that's the best way to share the contact information, if that is something that you allow me to do.
Yes, thank you so much.
Great, thank you. Well, thank you so much. It's 2:00.
Can I just make one more comment?
Sure, please go ahead.
Keep everyone on, but I think the most important thing that we're doing in regards to diabetes is really trying to get the whole organization working on what we call a weight-first approach. Really addressing overweight and obesity, and on an organizational scale, really from the perspective of preventing prediabetes and diabetes. But with providers specifically, we know that about 10% of overweight in the United States is actually caused by medications that we prescribe. Mm-hmm. So getting all of our providers to really be cognizant of the weight gaining potential of medications we're prescribing and really trying to use alternatives when possible. Really talking to everyone about lifestyle, of course, in a very broad sense with multiple team members, but then also doing offering medical weight management to both people with diabetes and people with prediabetes or not with diabetes yet. And so we do that both individually with primary care providers doing some of the management. I would say that's definitely a smaller but growing percentage. But then also through an intensive weight management program that's done with groups where every other visit is a medical visit with the medical providers individually, as well as every visit having about an hour of a team approach. So I just throw it out there because I think that's really where we need to be headed with diabetic management. That's what's going to get us better results in the long term.
Yep, that's a great comment. Thank you, Joy, for that great comment. And I totally agree with you. That's exactly the direction, and I'm quite sure that those who are going to listen to this recording are going to agree with you. Probably I'm going to get more questions from other from you. So thank you so much for sharing that. So it's 2:04, 2:05 p.m. Just need to be very, very conscious of your time. I want to thank you for participating on this call. It's been a pleasure. You are going to receive an email with some of the resources that we mentioned. If you have any questions, please send me an email, give me a call. And I want to thank you everyone for participating in the call, and happy holidays.
Thank you so much.
Thanks, you too.
Thank you. Bye.
Bye-bye.
Bye.